Okay, so here we go. Imaging of focal disease in the cirrhotic liver, introduction to LI-RADS. So the learning objectives for this last lecture are to focus in on patients with cirrhosis and ask ourselves, what is cirrhosis? Ask ourselves, what is the differential diagnosis for focal lesions in cirrhosis? We touched upon that in the last lecture. Ask ourselves, now this lecture is a little bit MRI focused, so a little bit on how MRI should be performed, the setting of cirrhosis, and how MRI should be interpreted. And for these last two things, how it should be performed and interpreted, I'll review the LI-RADS approach. So those are my objectives. My outline is the same. And so let's start with what is cirrhosis. So cirrhosis is an advanced stage of chronic liver disease in which the liver is divided by scars into nodules. So here is a cirrhotic liver on gross pathology. And if we take a little magnified view, we can see that in cirrhosis, we have these fibrotic scars which are stained blue. And these fibrotic scars divide the liver into nodules, which are stained red with this particular stain. So that's the definition of cirrhosis on gross pathology. And on MRI, we might similarly see, if we take a magnified view, that the cirrhotic liver is divided by fibrotic scars into nodules. And I didn't do a very good job, but I tried to draw the nodules by hand, and you can see I sort of got some and sort of didn't, but you get the point that we can see that the liver contains innumerable regenerative nodules surrounded by scars. But I don't want anyone to think that we can always tell when the liver is cirrhotic on imaging, because although on that previous example we can, sometimes we'll see a liver that looks like this on imaging. This is a 49-year-old man with hepatitis C. And we might wonder whether this liver looks a little too heterogeneous, a little too reticulated, but this could be a normal liver. Now, this particular patient has cirrhosis, but I don't think any of us would be able to look at this liver and say confidently that this is a cirrhotic liver. So the bottom line is that if the liver has a normal imaging appearance, that does not exclude cirrhosis. Imaging using morphologic manifestations has low sensitivity for the diagnosis of cirrhosis. Something else that we should be aware of is that cirrhosis is a common final outcome of many different diseases. So on your left are some of the most common causes of cirrhosis worldwide: hepatitis C, hepatitis B, alcohol, and NASH. On your right are less common causes of cirrhosis: autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis, etc. But any of these conditions, alone or in combination, can, as their final outcome, result in the formation of cirrhosis. Now, another question you might ask now that you know what cirrhosis is you might want to know, how common is it? And it turns out no one knows for sure. We know it's common. We know it's becoming more common. And we believe that by the year 2030, there'll be over 3 million Americans with cirrhosis, which means it'll be about 1% of the American population. So here's 100 Americans. So for every 100 Americans, one person will have cirrhosis. In some parts of the world, cirrhosis is probably more common. So in places like China, Korea, cirrhosis may be even more common because of the very large prevalence of chronic hepatitis B virus. In other parts of the world where there's very few risk factors for cirrhosis, cirrhosis is probably less common. But think about it. By the year 2030, by the time some of you will be finishing medical school, 1% of your patients will have cirrhosis, whether they know it or not. Okay, so that's what cirrhosis is. That's how common it is. What's the differential diagnosis for focal liver lesions and cirrhosis? And so we touched upon it on the previous lecture. I'll be presenting similar material, but in a different way. So in the cirrhotic liver, we have lesions and we have pseudo-lesions. Lesions are when there's an abnormality on imaging with a corresponding abnormality on pathology. A pseudo-lesion, there's an abnormality on imaging without a corresponding abnormality on pathology. because we sometimes don't know whether something's a real lesion or a pseudo lesion. See, if we always knew, then it'd be easier. We just call them either lesions or pseudo lesions. But because we don't always know, LI-RADS likes the term observation to describe globally to something we see, and we're not sure whether it's a lesion or a pseudo lesion. Now, within the category of lesions, we have a spectrum of cirrhosis-associated hepatocellular nodules that range from regenerative nodule all the way to progressed HCC. We can have non-HCC malignancies, such as cholangiocarcinomas, combined tumors, and METs, non-hepatocellular lesions, such as cysts and hemangiomas. We can have lesions that are not masses, like fat deposition, iron deposition, edema, or hemorrhage. We can have scars, which are bundles of collagen fibers that can sometimes look like masses, but aren't. And we can have treated lesions. Within pseudo lesions, we can have artifacts, something due to bad imaging signal. We can have vascular pseudo lesions, things due to arterial portal shunts. And sometimes in the setting of cirrhosis, we can have some areas that are less scarred than others. And because they're less scarred, they look hypertrophic and large, and they might actually look like masses when they're not, so-called hypertrophic pseudomasses. Now let's look at cancer. HCC is by far the most common cancer in the cirrhotic liver, but HCC is not the only cancer in the cirrhotic liver, because the cirrhotic liver also contains intrahepatic cholangiocarcinomas, or ICCs, and these comprise probably about 5% of all cancers in the cirrhotic liver. In addition, there are some cancers that can't make up their mind whether they want to be HCCs or cholangios. They have molecular and phenotypic features of both, and these are now known as combined HCC cholangiocarcinomas, and they comprise about 2% of all malignancies in cirrhosis. Very rarely, patients with cirrhosis can get other things such as metastases, sarcomas, and non-Hodgkin lymphomas, but those are quite uncommon. Now, you might wonder, who cares what kind of cancer it is? Cancer equals cancer equals cancer. Turns out that's not quite right. Different cancers have different prognoses. Different cancers have different treatments. In the United States, if you have just the right amount of cancer, not too little, not too much, the Goldilocks zone of HCC, the treatment of choice is liver transplantation. Now, that's not true necessarily in Korea, not necessarily true in Japan, not necessarily true everywhere in the world, but in the United States, stage T2 cancer, the treatment of choice is liver transplant, because liver transplant has been shown to be able to cure people with stage 2 cancer. However, liver transplant does not cure patients that have metastatic disease, does not usually cure people with cholangiocarcinomas or combined tumors. So liver transplant is not recommended in these other cancers. So now you can see why this distinction is so important, because one kind of cancer gets a liver transplant, the others do not. But it's more complicated than that, because not every lesion in the cirrhotic liver is in fact an overt cancer. In addition to these cancers, we have hemangiomas, scars, high-grade dysplastic nodules, low-grade dysplastic nodules, early HCCs, which are sort of carcinoma in situ, and cysts. And it's still more complicated because not every lesion in the cirrhotic liver is even a lesion. We have the pseudo lesions, usually due to arterial portal shunts, but sometimes due to hypertrophic pseudomasses, sometimes due to artifacts. And so the entire spectrum of observations in the cirrhotic liver is quite broad. And the question is, how do we tackle this very wide spectrum of observations? So before we learn how to interpret it, let's just spend a little bit of time on how MRI should be performed. And we will now segue into LI-RADS for how MRI should be performed and how it should be interpreted. So first of all, what is LI-RADS? LI-RADS is a system for standardization. It has an algorithm, and the algorithm has a decision tree and a diagnostic table, which we'll talk about later. This algorithm is supported by an atlas, a lexicon, and it is indexed and hyperlinked. The atlas and the lexicon together are a dictionary, that provide words and terms as well as their definitions. Now, LIRADS was developed and refined over many years. It was first developed in 2006 as an embryonic version at UCSD and at another North American center, Thomas Jefferson. In 2008, a committee was convened by the American College of Radiology, so the ACR LIRADS committee. After 3 years of iteration and lots of arguing, version 1 was released, which at that time had criteria and lexicon for CT and MRI with extracellular agents. 2 years later, we created an atlas. We added an algorithm, but notice it still applied only to CT and MRI with extracellular agents. In 2014, we added hepatobiliary agents such as gadoxetate. In 2017, we added ultrasound, contrast-enhanced ultrasound, treatment response algorithm, and we are now in the process of creating a manual. So at each time point, there were substantial updates, as I just mentioned. LIRADS applies only to patients at high risk for HCC, which for today's lecture means patients with cirrhosis, but it can also mean patients with chronic hepatitis B viral infection. It can also mean patients with current or prior HCC. So if someone doesn't have cirrhosis, doesn't have chronic hepatitis B, but for whatever bad luck they happen to have an HCC before, like you're an elderly man with diabetes and you have an HCC, then you have proven yourself to be at risk for developing HCC. So LIRADS applies to you. LIRADS does not apply to patients without those risk factors, doesn't apply to people less than 18 years old, so does not yet apply to children, and does not apply to patients with vascular disorders such as Budd-Chiari syndrome. Remember earlier in the prior lecture, I said that in Budd-Chiari syndrome, we get these hypervascular regenerative nodules. Some people think they may be adenomas. Those things look a lot like HCCs. So if we applied LIRADS in Budd-Chiari, we'd be misdiagnosing all these benign nodules as HCC. So don't use LIRADS in Budd-Chiari or in any other vascular disorder such as hemorrhagic hereditary telangiectasia. Now, the rationale is that in patients at high risk for HCC, a lesion that meets stringent criteria for HCC is HCC. So it's a combination of having high risk plus stringent criteria. This case I already showed you earlier. So this is a woman. This woman does not have cirrhosis. So if she did have cirrhosis, we would have said this is an HCC, but this particular woman does not have cirrhosis. So I'm going to go fast through this case because we already saw it. And the important point is that if this patient has cirrhosis, we can apply LIRADS. If this patient doesn't have cirrhosis, we must not apply LIRADS. Now, in addition to addressing the entire spectrum of lesions, which I showed you a few slides ago, LIRADS addresses the entire context of HCC imaging. So LIRADS applies to detection using ultrasound surveillance. LIRADS applies to HCC diagnosis using contrast-enhanced ultrasound, CT, and MRI. And LIRADS applies to treatment response using CT and MRI. So the entire gamut of different contexts of use. Today, however, in the interest of time, we'll focus on LIRADS for diagnosis using CT and MRI, and I'm not going to further talk about contrast with CEUS or with ultrasound or with treatment response. But I should mention that LIRADS contrast-enhanced ultrasound, there's one person in this room who has made tremendous contributions to that, and that's Alex Vezerides. So Alex, your turn to be just a little bit embarrassed, so raise your hand, please. Okay. So I don't know if you guys know that, but Alex has made tremendous contributions to contrast-enhanced ultrasound. In terms of ultrasound surveillance, you guys may not know this, but William Hong and Sudha Fazeli have, Sudha is, I guess she's one of the T2s that have dropped off, but William is still here. So William, raise your hand for your contributions to ultrasound LIRADS. In terms of treatment response LIRADS, Isabel Newton has made great contributions to that, although she's one of the T2s that never even came. So, but we can still acknowledge her contributions. And then for CT and MRI, really, I mean, like half the people in this room have contributed. You know, so Yesenia and Adrija and William and Ethan and Jennifer and now Chathan have been making. And if I didn't give you credit, you deserve credit. I apologize. I just want to basically say that a lot of people have contributed to this. So thank you. Okay, so how do we do it? Well, LI-RADS doesn't want to be too prescriptive on how to do it, but if we're using an extracellular agent, then LI-RADS would like you to get in and out of phase imaging, some kind of T2, some kind of diffusion weighted imaging, and then dynamic imaging with arterial phase, portal venous phase, and delayed. And if you're doing MRI with an extracellular agent, it's very similar, except that we ask you to get a hepatobiliary phase at about 15 or 20 minutes. If you want to learn more about LI-RADS technique, you can visit this website and you can download these documents, and coming soon will be the LI-RADS manual. And here are some members of the technique working group. This working group is led by Avinash Kambadakone from MGH. And here's a face that you guys may not yet recognize, but you will. So Catherine Fowler is a faculty member at Mallinckrodt. She's one of the really top radiologists in the United States, and she's going to be joining the faculty at UCSD in September. So we're very, very lucky to have successfully recruited Katie Fowler to UCSD. So many of you will be meeting her in just a couple months. Okay, so how should MRI be interpreted? Well, CT and MRI begins with an observation. So this liver is cirrhotic. We can see that it's nodular. We can see that within the liver, there's all of these smaller nodules surrounded by fibrosis, and we're looking for something in this cirrhotic liver that looks different than the background. And there we see a small nodule that looks different than the background liver. It's distinctive from the background liver, so this is an observation. Once we've seen the observation, we basically ignore the background liver, and we now focus in on that observation and try to characterize that observation by looking at the observation's imaging features. So we look at imaging features such as AFI, washout, capsule, size, growth, etc. And based on these various imaging features and combinations of features, we then assign a LI-RADS diagnostic category that include LRNC, LRTIV, LR1 through 5, and LRM. Now, one question you might ask is, why do we assign categories? Because in an ideal world, we would not assign categories, we would assign an exact probability of malignancy. So if we had this observation over here, we would be able to put this observation onto this continuous spectrum of a probability map and say that this lesion has a 99% probability of being malignant. In addition, not only would we be able to say what the probability of malignancy is, but in addition, we would also give a probability of the cell type and say something about whether we thought the lesion was or was not of hepatocellular origin. So is this lesion not an HCC? Is this lesion an HCC? And in this case, we would like to be able to say that there's a 99% chance this lesion is a cancer, and there's a 98% chance that this lesion is an HCC in particular. Well, that would be ideal, but this is not possible in the year 2018. We do not have that knowledge, that technical capability. So instead, LI-RADS converts this continuous spectrum of probabilities into ordinal categories which define relative probabilities of these things. So LI-RADS 1 is definitely benign. LI-RADS 2 is probably benign. LI-RADS 3, intermediate probability of malignancy. LI-RADS 4, probably HCC, definitely HCC. LI-RADS M, probably or definitely malignant, not necessarily HCC. So LI-RADS 5 is a very important category because you're basically saying this is an HCC. There's no other differential diagnosis. LI-RADS M is also very important because you're saying this is almost for sure a cancer. I'm just not sure what kind of cancer it is. And remember earlier that the kind of cancer does affect the prognosis and the treatment. LRTIV, another important category because it means there's now a cancer that's growing into the lumen of a vein, so-called tumor in vein. And this is important because if the tumor has grown into the vein, it has probably escaped the liver and formed metastases elsewhere, even if the metastases are not visible. So if you have tumor in vein, do you think you want to do a liver transplant? Because if you do a liver transplant, you remove the liver, but you don't remove the metastases that have already escaped. And then you put the patient on immune suppression so they don't reject the liver transplant. And if you suppress someone's immune system, what happens to all these little tiny metastases? They grow very, very fast. So if you do a liver transplant in someone who has metastatic disease, all you have done is hasten their death. So you do not want to do a liver transplant in someone with LRTIV because the probability is very high that they already have metastases outside the liver. LRNC, not categorizable. How are we going to assign these? We're going to do it in 4 steps. So step 1, we apply the LI-RADS algorithm. Step 2, optional, we apply ancillary features. Step 3, only if needed, we apply tiebreaking rules. Step 4, final sanity check. Does it make sense? If it makes sense, we're done. Let's start with applying the LI-RADS algorithm. The LI-RADS algorithm has a decision tree and a diagnostic table. So the decision tree is shown here, the diagnostic table is shown below. So here's the decision tree. Let's focus in on this decision tree. So here's the decision tree, and once you get used to using LI-RADS, this decision tree is very easy to use. It takes just literally sometimes even a 1/10 of a second to go through this decision tree. It's very, very fast. So the first thing we do is we ask ourselves, is there an untreated observation? What is an observation? Well, we already talked about it. It's an area distinctive from liver. It could be a mass, it could be a nodule, it could be an infiltrative mass. It may be a lesion that's not a mass at all, like scarring, or it could be a pseudo-lesion, like an arterial portal shunt. We ask ourselves, does the patient have high risk for HCC? What does that mean? Well, we've already talked about it. They either have cirrhosis or chronic hepatitis or current or prior HCC, and they must not be a child. They must have one of those risk factors, and we don't want to use LI-RADS in someone with Budd-Chiari. So if we don't have one of these things, then we stop. We don't use LI-RADS. So let's say these things apply, so we're going to continue LI-RADS, and we ask ourselves, can I categorize this lesion? If you cannot categorize this lesion at all, we call it LRNC. So LRNC means we see an observation, but due to image degradation or due to image omission, we cannot tell if this observation is more likely benign or malignant. So I'm looking at this sort of blob of enhancement there, and I have no idea if this is an artifact, if this is a cholangiocarcinoma. This could be nothing. This could be a devastating malignancy. I have no way of telling the difference based on these horrible images. So I apply LRNC, non-categorizable. So non-categorizable means you cannot tell whether it's more likely benign or malignant. If the images are a little bit degraded, but you can still put it into this category, or if the images are degraded, but you can still put it into this class of categories, don't call it LRNC, then do the best you can at categorizing it. So if I really can't tell which of these it is, I'll say the images are degraded, but I'm worried this is malignant. This is either an L4, L5, or LRM, but I would not call it an LRNC. Okay, if then I see a tumor in vein, if it's not non-categorizable, I ask myself, is there tumor in vein? So if there's tumor in vein, and what I'm looking for is I'm looking for enhancing tissue in the lumen of the vein. So here we have enhancing tissue in the lumen of the vein. And the reason I know we have enhancing tissue in the lumen of the vein is I look at this portal vein and I see a plug of enhancement. I look at this portal vein and I see nothing. Now, incidentally, this is an overly early arterial phase, but just by luck in this particular patient, this overly early arterial phase shows me the tumor in vein here. This portal vein doesn't yet have any contrast. 20, 30 seconds later, look what's happened to this plug of tumor. This plug of tumor has now faded, even as the right portal vein has enhanced. So this is enhancing soft tissue within the vein. This is the definition of tumor in vein, unequivocal enhancing soft tissue in vein. Notice that we don't have to see a parenchymal mass, and in this particular case, I don't see a definite parenchymal mass. I just see the tumor in vein. Now, does this patient have a parenchymal mass? This patient must have a parenchymal mass because the tumor probably started in the parenchyma and then grew into the vein. But sometimes you don't see the parenchymal mass. You still call it tumor in vein. If I don't see a tumor in vein, then I ask myself, do I see something that's definitely benign? Do I see something that looks like a cyst or a hemangioma, something that's definitely an arterial portal shunt? If I see something that's definitely benign, I call it LR1. If I see something that's not definitely benign, but probably benign, I call it an LR2. So notice that definitely benign is definite cyst, definite hemangioma, definite perfusion alteration. LR2 is something that looks like a cyst, looks like a hemangioma, looks like a perfusion alteration, but I'm not positive. It looks a little funny, so I call it probable cyst, probable hemangioma. And in the interest of time, let me skip this last category here, and that's something that we can discuss on another day. Now, if it's not definitely benign and not probably benign, then I ask myself, is it probably or definitely malignant, but not HCC specific? And if it is, I call it LI-RADS-M. Now, the first thing we want to talk about LI-RADS-M is what are LI-RADS-Ms? Well, remember, a LI-RADS-M is probably or definitely malignant. And what are the most common malignancies in the setting of cirrhosis? Well, the most common is HCC. The second most common is cholangio. The next most common is combined HCC cholangio. But because these LRMs don't meet imaging criteria for HCC, they're not typical HCC. So that's why the differential diagnosis for LRM is about 40% HCC and about 60% all of these other things. Does that sort of make sense? HCC is the most common cancer in cirrhosis. So if I see, but if I see something that's a cancer but doesn't look like an HCC, then HCC is no longer the most likely thing, right? Because it doesn't look like an HCC. Turns out about 40% are HCC and about 60% are these other things. But this is what I want to emphasize. You call it an LRM when you see targetoid enhancement. Now, targetoid enhancement can have different manifestations. Rim-Affy, peripheral washout, delayed central enhancement, targetoid restriction, targetoid appearance on the transitional phase, targetoid appearance in the hepatobiliary phase. In the interest of time, let me not go through all of these. Let me just focus on two, Rim-Affy and peripheral washout. So here are 5 examples of Rim-Affy, all in the cirrhotic liver. And these patients have the following lesions, as shown over here. So notice that all of these lesions are cancer. In this case, one is a cholangio, one is a combined tumor, one is a sarcoma, one is a lymphoma, and one is a colon metastasis. Notice they are all cancers. In this particular case, none of them are HCCs. So when I see Rim-Affy, I think malignancy, and I call it an LRM because it may not be an HCC. So all of these have Rim-Affy. Now, another example of targetoid appearance is peripheral washout. And here we have an example of peripheral washout. So the lesion enhances in a rim-like fashion in the arterial phase. And notice that on the most delayed images, the periphery washes out. Now, some of you, this is a more advanced question. Some of you might notice that Rim-Affy and peripheral washout tend to coincide. And so then the question becomes, is peripheral washout superfluous? Do we ever see peripheral washout without Rim-Affy? If the answer is that peripheral washout is superfluous and we never see peripheral washout without Rim-Affy, then we can get rid of peripheral washout as an imaging feature because it adds nothing. but we do not yet have that knowledge. What happens when we don't have knowledge? We do research. So this would be an interesting research question for every single person in this audience to pursue. And I strongly recommend that every single person in this audience pursue it. And we can make it like a competition. Whoever gets there first gets to write the paper first. I'd like to be the first author, if you don't mind, though. Okay. Now, why does targetoid suggest non-HCC malignancy? Because non-HCC malignancies, such as cholangiocarcinomas, tend to be arterialized and hypercellular on the outside, and they tend to be fibrotic and ischemic in the center. So if something is arterialized on the outside, it tends to have rim-aphy. If something is hypercellular on the outside, it tends to have restricted diffusion on the outside, less restricted diffusion on the inside, and that's targetoid restriction. If the outside let me skip this in the interest of time, but the point is that the pathophysiology explains the imaging, and here are different imaging examples of rim-aphy, peripheral washout, delayed central enhancement, targetoid appearance in the transitional phase, and targetoid restriction. Okay, so if it's not a LI-RADS-M, then we go to the CT MRI diagnostic table, and if it's of intermediate probability of malignancy, we call it LR3, probably HCC LR4, definitely HCC LR5. So now let's go to this diagnostic table, and shown here, and this diagnostic table will allow us to categorize the things that are not LRNC, the things that are not TIV, the things that are not 1, 2, or M. So we exclude all of those things, and now we're going to categorize 3s, 4s, and 5s based on this table. Notice that in this table, we look at arterial phase hyperenhancement, and we classify things as either having no aphy or aphy. And if there's aphy, we want to make sure it's not rim. Because if it is rim, we realize we made a mistake. We have to go back to the diagnostic decision tree and call it an LRM. Okay, so another thing we're going to look at is the observation size. And the key sizes are 10 and 20. And we'll show some examples in a moment, but these are in millimeters. The key sizes are 10 and 20. And then we have to count the number of additional major features, such as washout, enhancing capsule, and threshold growth. And for washout, we want to make sure it's not a peripheral washout, because remember, peripheral washout is a feature of LI-RADS-M. We then count the number of those major features. It's either none, 1, or 2 or more. And based on all of that, we assign a LI-RADS category. Now, there's one cell that has 2 possible categories. That's LI-RADS-4, LI-RADS-5. This one has 2 possible categories. And observations in this cell are either a LI-RADS-4 or a LI-RADS-5. So generally, we call them LI-RADS-4, but there's 2 exceptions. If the lesion is growing, we call it a LI-RADS-5G, G for growing. If the lesion has washout and was visible at ultrasound, we call it a LI-RADS-5US. Now, this cell is kind of complicated, and we're in negotiations right now with AASLD to see if we can simplify this cell for the purposes of congruency. So this cell is probably going to change its definition in the next couple of months. So I don't want to spend too much time on this cell, because in a few months it's going to be simpler, it's going to be easier, and it's going to be better. But that's what the cell looks like right now. Okay, now, if unsure, so what if after all this you're unsure? Actually, let me slow down, sorry. For each one of these features, aphy, washout, capsule, growth, if you're not sure about that feature, characterize that feature as absent. So if you're not sure whether something is present, it is not present. Let's look at some examples. Here we have a man, and this man is cirrhotic. We see that the liver has all of these internal nodules. And we ask ourselves, does this patient have an observation? And yes, there's an observation in this liver that looks different than background. How big is this observation? This observation measures 18 millimeters. We like to measure observations on the portal venous or delayed phase if they are visible on the portal venous or delayed phase. We try not to measure observations on the arterial phase unless the observations are visible only in the arterial phase. We measure from outer edge to outer edge. This observation is 18 millimeters. Notice that this observation has aphy. It enhances more than background liver, and this aphy is not rim-like. Notice that this observation washes out to become darker than liver in the portal venous phase, and this washout is not peripheral. This is non-peripheral washout. The whole thing washes out. Notice that on the delayed images, this observation has an enhancing rim of enhancement that is thicker than the fibrosis surrounding the background nodules. So this is an enhancing capsule. So now let's categorize it. It has aphy. The observation is 10 to 19 millimeters. So it's in this column over here. The observation has washout and capsule. That's 1 plus 1 equals 2. It's over here. What row is that? It's that row over here. This is LR5, definite HCC. Let's look at this example over here. This patient has an observation. How big is this observation? This observation, again, is measured not on the arterial phase. We measure on something else. Outer edge to outer edge, this is 27 millimeters. This observation has non-rim aphy. And notice on the delayed images, this lesion becomes darker than background liver, so it has non-peripheral washout. Now, some of you might appreciate that there's a rim of enhancement around this observation, but this rim of enhancement is not thicker than the fibrosis surrounding the background nodules, so this does not qualify as an enhancing capsule, and I would say this observation only has non-peripheral washout. So how do we categorize this lesion? It has aphy. It's bigger than 20 millimeters. So it's in this column over here. It has washout only. Washout only is 1. It's in this row. And this is a LI-RADS 5, definite HCC. How about this observation over here? Well, here we see it. Now, this observation, we do not see on the portal venous phase. We do not see it on the delayed phase. It fades, so we have no choice. We must measure it on the arterial phase. So we measure it on the arterial phase, and this lesion is 13 millimeters. So now we go to our table. It has non-rim aphy. It has no washout and no capsule. So here we go with aphy, and the module or this observation measures 10 to 19 millimeters. It has none of these additional major features, so this gets LI-RADS 3, intermediate probability for HCC. How about this observation over here on CT? First of all, is there an observation? Yes, there is. This observation measures what? This observation measures 35 millimeters. This observation does not have aphy. Notice that it's invisible in the arterial phase, but this observation has washout, and this observation has an enhancing capsule, which you can appreciate over here. So what is the LI-RADS category here? Well, it's no aphy. It's more than 20. It has 2 of these, so this is a LI-RADS 4. I don't know if I may not have animated this one yet. So here we have a small, okay, I'll have to skip this. This one's not ready. Sorry. This case was great though, trust me, it was fantastic. Here's another fantastic one, but it's not done yet, sorry. And this one's another great one, not done yet. Oh God, how many of these do I have? Okay, sorry, we're almost done. Okay, I just want to show you one thing here though. So let me ignore my animations here, what I want to point out here is the following, that a lot of radiologists will say that a lesion like this has washout. because it hyperenhances, and then on these more delayed images, it sort of looks like it might be darker than the liver. It certainly is darker here than it is here, right? So radiologists will often say that this has washout, but this is not washout. This is the optical illusion or the visual perception of washout caused by the fact that there's a capsule. So I'm going to do something now that I recommend that you never ever do without telling people you're doing it, but I am now going to electronically remove that capsule. And when I electronically remove the capsule, see, I'm telling you I'm doing it. So if you tell people you're doing it, it's not cheating. So I remove the capsule electronically, and you see how that nodule is gone? So it didn't wash out. It was the optical illusion of washout caused by the presence of a capsule. Okay, so let me skip ahead because I don't want to kill you guys with this. Okay. Okay, so if after doing all that, you now have at your option the ability to apply ancillary features. So ancillary features can be applied to improve detection, to increase your confidence, or to adjust the category. So let's talk about adjusting the category. So you can apply ancillary features to increase the category by 1. So for example, you can go from 1 to 2 or from 2 to 3, but you can't go from 1 to 3. And also notice that you can go from 3 to 4, but you cannot go from 4 to 5. So one teaching point to be made is that ancillary features cannot be used to upgrade to LI-RADS 5. And there's a few reasons why we do that. But one is that other societies such as AASLD do not recognize ancillary features. And another reason is we don't yet have enough knowledge in the year 2018 to know how to apply ancillary features to raise the category from a 4 to a 5. So we do not yet allow upgrading from a 4 to a 5. Now, that's if you have ancillary features favoring malignancy. Sometimes we have ancillary features favoring benignity, and these can be used to downgrade by 1 category, but only by 1 category, not by 2. So here is a list of the ancillary features favoring malignancy, and these can be divided into those that favor malignancy in general. So for example, growth or restricted diffusion, as well as features that favor HCC in particular, such as nodule in nodule or mosaic architecture. Ancillary features favoring benignity are shown on the right and include things such as size stability or spontaneous size reduction. Now, I'm not going to go into all of these ancillary features. Suffice it to say that they exist. Some favor malignancy in general, some favor HCC in particular, and some favor benignity. So here's an example of ancillary features in action. So here we see a patient. This patient has chronic hepatitis B, so LI-RADS applies. And we see a small enhancing observation right here. So this is arterial phase hyperenhancement, and in the portal venous phase, it does not wash out. So based on this appearance, this would be considered probably a LI-RADS 3, intermediate probability for HCC. But then we go to the hepatobiliary phase, and we notice that it is hepatobiliary phase hypointensity, and this allows us to raise it from LI-RADS 3 to LI-RADS 4. Now, this particular lesion also contains intralesional fat and also has restricted diffusion and also has mild to moderate T2 hyperintensity. So all of these are also features that favor malignancy, but no matter how many features favoring malignancy I cannot go from LI-RADS 4 to LI-RADS 5. So this is a LI-RADS 3. With this, it becomes a LI-RADS 4, and these other things just give me more and more confidence, but they don't allow me to bump it up to a LI-RADS 5. Now let's skip this in the interest of time. Now, if ancillary features conflict, do not adjust the category. So if I have one ancillary feature favoring malignancy, and I have one ancillary feature favoring benignity, do not change the category. Even if I have 10 ancillary features favoring malignancy, do not adjust the category. Even if you have 1 million ancillary features favoring malignancy, if you have just one favoring benignity, Do not adjust the category. Okay, if needed, apply tie-breaking rules. So what about if after all of that, you're not sure, is it a 2 or a 3, is it a 4 or 5, then you apply the tie-breaking rules. So if unsure about the presence of tumor in vein, do not categorize as tumor in vein. So if you're not sure whether it's a tumor in vein or not, don't call it. Similarly, if you're unsure between two categories, choose the one reflecting greater uncertainty. So if you're not sure between a 1 and a 2, choose a 2. If you're not sure between a 2 and a 3, choose a 3. On the other hand, because you're moving away from benignity. On the other hand, if you're not sure between a 5 and a 4, pick a 4. If you're not sure between a 4 and a 3, pick a 3, because now you're moving away from malignancy. And what about if you're not sure between a 5 and a 4? Well, again, pick lower uncertainty and go to M, because this is reflecting lower certainty of the hepatocellular origin. Same thing with 4 versus M. If you're not sure between a 4 versus M, call it an M. And finally, check yourself. Ask yourself if the assigned category seems reasonable and appropriate. If yes, you are done, move on to the next observation. If no, you might have made a mistake, so start over again. Now, some of you might be wondering, where's the evidence? And the evidence is starting to become available. So there have been 1, 2, 3, 4, 5, 6, 7 papers published in the last 2 years that have looked at the probability of HCC for different LI-RADS categories. Now, I did not do a formal meta-analysis. I simply counted the numerator and denominator for every paper. And when I do that, I find that I get a curve that looks like this. So in the published literature, 0% of all LR1s have been malignant, 6% of LR2s have been malignant, 36% of LR3s have been HCC, 72% of LIRADS 4s have been HCC, 96% of LR5s have been HCC. So this seems like it's working quite well. Now you might argue it's not perfect because we want this to be closer to 100%, but this system that we created seems to be working quite well according to the published literature. And 3 separate or 4 separate papers have looked at the probability of cancer for LI-RADS M. So far, the published literature, 98% of LI-RADS M's are malignant, 40% are HCC, 56% are other malignancies, and then 2% have been benign. Okay, so to summarize, we started by talking about what cirrhosis is, we talked about how common it is, and we talked about the differential diagnosis of focal liver lesions in cirrhosis. We spent a little bit of time talking about how MRI should be performed, and then we spent the chunk of our time talking about what LI-RADS is. We talked about how LI-RADS should be interpreted. We talked about the decision tree. We talked about the diagnostic table. We emphasized that we do not apply LI-RADS in patients in whom it should not be applied. And we worked through a few examples that I had prepared for you. And then unfortunately, we suffered through a lot of cases that I forgot that I had put in there, but had not yet animated. So I apologize for that little snafu. Obviously, I've got to do a little bit more work in the background. But I would like to conclude by thanking you all for staying to the bitter end. I don't know whether some of you did it because you wanted to, or you did it because you felt like you had to. But regardless of what your motivation was, it is very appreciated by me that you suffered through this. So thank you very much.